Okay, we're back with the evaluation and treatment of this very, very severe condition of rhabdomyolysis, which produces myoglobinuria. Um, so obviously the priorities for treatment include identifying and treating the underlying cause that's causing it, and hopefully we can stop that. Malignant hyperthermia and myoglobinuria, again, can be treated by infusing dantrolene sodium or dantrium, diluting the pigment using intravenous fluids, and administration of mannitol, which we know is a osmotic diuretic, sodium bicarb, and Lasix to flush the kidney have been advocated to prevent renal failure. We're also going to be using anti-inflammatories, analgesics. I would assume that they're in some type of pain if they've sustained some type of a crush injury. Hemodialysis for renal failure, which would be really appropriate. We want to get the kidneys flushed out of this horrible pigment from the wasted, crushed muscle of myoglobulin before they fail. And they would be on hemodialysis until that myoglobulin has cleared. Bed rest and IV hydrating as early as possible. Okay, so now we're going to move on to osteoporosis, which is a metabolic bone disorder. We've got a bone resorption accelerating, meaning the breakdown of bone, and the rate of bone formation slows. So we've got less bone, and we've definitely got less dense bone, causing a loss of bone mass. Bones affected lose calcium, phosphate salts, and become porous and brittle, meaning they're not thick, they're not dense, and abnormally vulnerable to fractures. Trabecular bone is impaired. Major risk for persons with osteoporosis are fractures because we don't have a dense bone, we have a soft bone. We have thin, soft bone. Men lose bone density, but they start out with higher bone density. So they reach osteoporotic or bone softening levels at older age than women do. At age of 90, about 70% of males have had a hip fracture compared to 32% of females, so it's almost double. Over half of all adults hospitalized for hip fracture do not return to their formal level of functioning. Trabecular bone, or soft spongy bone with open spaces. Spaces are filled with marrow and have a honeycomb appearance. Throughout lifetime, old bone is removed. We know that resorption and new bone is added to the skeleton. During our childhood and teenage years, new bone is added faster than old bone is removed. Consequently, bones become larger, heavier, and denser. Bone formation continues at a pace faster than resorption or breakdown until the peak bone mass or maximum bone density and strength is reached. And you probably would never guess this age. I think a lot of us would say 12. Some people would say 18, 20, 22, because that's at an adult age. But the peak bone mass or maximum bone density and strength is reached around the age of 30. After 30, bone resorption slowly exceeds bone formation. So it starts going inverse. We don't have more forming, we have less forming and more being broken down. In women, bone loss is most rapid in the first years after menopause, but persists throughout postmenopausal years. It's estimated that 55% of people 50 and older have either osteoporosis or a low bone mass. Vertebral fractures in our spine occur in the 6th and 7th decade of life. Most common in whites. Blacks have half the fracture rates than whites, but if you remember back to one of the first strains we talked about, blacks also have denser bones than Caucasians. Not necessarily a consequence of the aging process. Some elderly people retain strong, dense bones. So I'm giving you just statistics as usual. It's not all old people. Some old people have very thick, good bones. Again, processes where the old bone is being resorbed faster or broken down, and the new bone is being made faster than the new bone can be made, causing the bones to lose density, becoming thinner and more porous. Postmenopausal osteoporosis, the bone loss that occurs in middle-aged and older women, can occur because of the estrogen deficiency. And remember, we said estrogen helps with calcium uptake and release. It helps regulate osteoblastic activity. And perimenopausal and menopausal women have a diminished amount of estrogen. Let's see. A progressive loss of bone mass may continue until the skeleton is no longer strong enough to support itself. Eventually, bones can fracture spontaneously from this condition. So something to keep an eye on and be aware of. As bone becomes more fragile, falls or bumps that would not have caused a fracture previously in your life will now cause a fracture. Osteoporosis appears to be most severe in the spine, wrists, and hip. And again, hip is not the joint you want to horse around with. Postmenopausal changes is a remodeling imbalance between the activity of the osteoclasts, or the bone destroyers, and the osteoblasts, or the bone formers. A combination of an inadequate dietary calcium intake and a lack of vitamin D, possibly decreased magnesium, lack of exercise, low body mass, and family history can contribute to this. Hormones most commonly associated with osteoporosis are parathyroid hormone, that's where we get the calcitonin and the calcium, cortisol. Thyroid hormone is a very important growth hormone, and then the growth hormone itself. Increased formation of osteoclasts, again, those are going to be the bone destroyers, that cause removal or resorption of bone, results in a cascade also of pro-inflammatory cytokines. Increased cytokine activation, especially the TNF, the tumor necrosis factor, can occur with declining estrogen levels. So that's definitely going to add to the deterioration of bone. It's not going to help it. Evaluation and treatment, usually it's by an x-ray. Estrogen replacement, you got to be really careful with this one because estrogen can cause cancer. Androgen, testosterone, and dihydrotestosterone, or testosterone, stimulate bone formation. Again, women have more, and a lot of women don't want to take androgens because they have male characteristics. A smaller chest, they might have an Adam's apple. They're going to get hair in places they don't usually have it, like on their face, a mustache. So they're not going to want it. By the time abnormalities are detected by an x-ray, up to 25 to 30% of bone tissue may have been lost. And again, estrogen replacement can slow bone loss around the time of menopause, but fractures in older women have still occurred. Plus, you've got the cancer scare, so I don't know if that's an appropriate treatment. High intake of phosphorus may neutralize calcium, interfering with its benefits. In some cases, reverse demineralization because the mechanical stress of exercise stimulates bone formation. Okay, treatment of osteoporosis is important to reduce the risk of falls and enhance one's quality. Exercise program to enhance strength has the added benefits of reducing the risk of falls if they feel stronger all the way around, and promoting bone quality. The goal of osteoporosis treatment are to slow the rate of calcium and bone loss and to stop the disease before it progresses too far. It's hard to make new bone if we've got processes in place that won't. So let's just try to slow the process down. We've got a couple medications here. Strontium increases in bone mineral density, and the teriparatide, it's a form of a parathyroid hormone, so it's going to elicit calcitonin and calcium. The person may need a back brace. They may need surgery. They may need physical therapy, analgesics, and local heat to relieve pain. Okay, now we're going to go on to osteomyelitis, which is basically a bone infection. It's often caused by, number one reason is Staphylococcus aureus, caused by bacteria. It can also be caused by fungus, parasites, and of course viruses. We've got exogenous and endogenous osteomyelitis. Exogenous is from the outside in. So it's an infection that enters from outside the body through an open fracture, penetrating wounds, surgical procedure. Infection can spread from soft tissues into adjacent bones. And then we've got endogenous osteomyelitis, which there can already be an internal infection. So it didn't come from the outside. It came from inside the body, and it's carried in the bloodstream from sites of infection to bones in the body. Infection spreads from the bone to adjacent soft tissues. More endogenous than exogenous are found in infants, children, and the elderly. Again, Staph aureus leads it, but you can also get osteomyelitis from group B strep, influenza, and salmonella. Cutaneous is skin. Our sinuses, ear, and dental infections are the primary sources of bacteria, again, because they lead from the outside the body in. Dental is very, very, just have to be aware, it's a really good dentist because the mucous membrane around the mouth is full of blood, so it can get into the bloodstream. It's also in pretty close proximity to the brain. So sometimes dental work can really, really wreak havoc if the instruments aren't sterile, if they break sterile technique, coupled with the fact that the mouth is just covered with bacteria. Our mouth has a lot of bacteria in it. And infections that occur after total joint replacements, because that's a really big surgery and it's surrounded by bone joints, obviously. In adults, it's more common in the spine, pelvis, and small bones. Exogenous osteomyelitis, again, that's from the outside in. It can be caused by human bites also. And fist blows to the mouth when people get in fist fights. Superficial animal or human bites, that makes sense. Most common infecting organism in a human bite is, again, Staphylococcus aureus. Animal bites, the infecting organism is the Pasteurella multocida. It's part of the normal flora for mouth of cats and dogs, and those are domestic pets that most people have. So they can get osteomyelitis from that. We have to be very careful with our pets. Clinical manifestations of a bone infection are fever, malaise, anorexia, weight loss, pain. Like a lot of the infections, you're going to have pain, fever, malaise. It's like you just really, really feel sick. You can have a recent infection, or UTI, respiratory, skin that can develop into this especially if your immune system is already altered. And it's going to be altered by another infection anyway. Instrumentation through a catheterization of any kind, cystoscopies when they go and look inside the bladder, myelography, discography if they're looking at muscles or inside your spine, can precede onset of symptoms. Single or multiple abscesses characterize subacute or chronic osteomyelitis. And these are Brody's abscesses. Again, I'm sure the person that coined its name was Brody. Are circumscribed lesions, very identifiable lesions, 1 to 4 centimeters in diameter, usually in the ends of long bones and surrounded by dense ossified bone matrix. So they can see these Brody's abscesses through an x-ray. And then exogenous, again, from the outside in, symptoms of soft tissue infection predominate. Inflammatory exudate in the soft tissues disrupts muscles and supporting structures and forms abscesses. Low-grade fever, we've got a large lymph floating around in the blood trying to help. Local pain and swelling occur within days after obtaining a puncture wound. So evaluation and treatment, I will follow with that on the next video, and then we'll go into osteoarthritis, rheumatoid arthritis, gout, and then we'll be done.